Good afternoon, everybody. Thank you so much for joining us for today's speaker series. My name is Stephanie, and I will be monitoring things here on the back end. We will have time for questions and answers. So if you have any questions or answers, you feel free to put them in the Q&A or the chat. I have both of those open for your use. Our next speaker series will be in person at the U of M Detroit Center on April 16th. It's going to be an Ask the Experts question and answer panel. That will go from 10 until noon with lunch provided, and that will be at the U of M Detroit Center. So if you're in the area, please look into it. We'd love to see you in person. Towards the end of this activity, I will be sending out a Qualtrics evaluation. So please take the time to fill out the evaluation so we can learn about different topics and ideas that you'd like to hear in our speaker series in the future. And with that, I'm going to introduce Dr. Sheria Robinson-Lane. She is a gerontologist with expertise in palliative care, long-term care, and nursing administration. Her work aims to reduce health disparities and improve health equity for diverse older adults and family caregivers managing pain and chronic diseases such as Alzheimer's. With that, I will turn things over to you.
Good afternoon. I'm glad that so many of you are able to join today. I see a lot of familiar names out there, and so I hope that we're able to have a good discussion and that you find some things that are helpful to you today. So, of course, the topic is on really thinking about family, and particularly, we're talking about family care partners today and how to improve the support for individuals um, so that it is meeting the diverse needs of our families, just like our families are diverse. They have, diverse sorts of needs. And we want to think more about how are we developing programs that support our families and the intergenerational sorts of support that they are providing, the different socioeconomic needs, the different times that they're available, the different roles that they have in the family, rather than sometimes what our traditional programs look like that are centered around spouses. And so we'll talk a bit about some of the strategies that I've used in order to make that happen, and more specifically, how that has resulted in the current work that I'm doing in advancing a particular virtual support program for caregivers. So we don't have like a ton of time today. There's never enough when it's time to talk about some of my favorite topics, which of course family caregiving is one of them. But the plan for the next, hour-ish is to talk a bit more about disparities in family caregiving. We'll talk about what stress looks like within this population and how to identify some of the factors that are associated with care partner stress. And then we'll end with the particular program that we've been working on, which is a culturally responsive approach toward care partner success. So, as we know, health disparities are preventable differences in health outcomes. And so it's not just that when we talk about disparities, we're talking about differences in health. The key is that all of these differences are preventable, the differences in health outcomes. They're things that we can address by more upstream thinking, by increasing the access, the support, looking at the systems that lead to inequities in how people are able to adjust to changes in health. And so, in the case of dementia family caregiving, the change in health that we're, of course, talking about is a new dementia related diagnosis. And all of the support folks that come in to support this older adult that wants to continue living independently as much as they're able to, in the community. And so, at which stages might it be different in which some individuals get more access to the system, whether it's access to a diagnosis to know exactly what's happening, whether it's when families become engaged, so families are aware what's happening, what sorts of insurance individuals have, and the actual cash reserves that can make a difference in the support, the extra support that they're able to receive versus what they have to do on their own. All of these are the sorts of things that we're talking about when we talk about preventable differences that can change some of the outcomes that we see between, within families and the individuals who are providing care. And so largely, these differences are determined by what, many of us are aware of are called social determinants of health. And so these are social factors, or sometimes called, contextual factors that arise that can make a difference in how we make decisions, and how we access care. So, of course, at the top of the list is economic stability plays a large role, right? So, whether or not a person is employed or unemployed plays a large role in what their availability is in order to engage in caregiving sorts of activities, how long they can even stay employed, right? If you have a lot of caregiving activities that are causing interruptions to one's job, you might have to leave the workforce before you're maybe financially inclined to do so, which then, of course, can play a role on your income. Separately, income and access to financial resources play a large role in how you're able to support the person that you are caring for, as well as like if there's a reciprocal relationship and you actually are reliant financially upon the person who's developed a cognitive impairment or a dementia related diagnosis, and the level of obligation that then, comes with supporting them in order to maintain different language to talk about dementia, like whether calling it dementia versus Alzheimer's disease versus mild cognitive impairment, what that means, and how it can affect the sorts of behaviors and care expectations that are out there. Language barriers can play a role as well in understanding um, how an individual can just understand what's taking place, right? So if somebody speaks a language other than English, if English is not their first language, that can make it really challenging to navigate the system, as well as particular social context, like what sorts of support systems do individuals have available to them? Who is in their circle of support? What if it's somebody that does not have a large circle of support? Perhaps they have isolated themselves from other individuals, or they simply are far away from home, and their hometown and the people that typically would support them. And then who are the created systems? So, like, how does the community then come in, or the made family, to make a difference for individuals? And how does the ways in which a person was raised affect the manner in which they are prepared to deal with stress, right? And so, because one of the things that when we talk about like culture, one of the key things that culture helps individuals to achieve is it helps them to survive in the world. So if your culture are the groups of individuals that are around you that teach you how to survive in the environment that you're in. And your first cultural group is the family who raised you, and then that extends until your friends, your family, your schoolmates, your job, that also becomes your religious community. All of these things become an embedded part of your culture that teach you how to survive in the world, and how to present in the world as well. That also influences your stress perception and how you think about what things are bothersome and what things are not bothersome and how you respond to those things. So all of those affect your decision making. And then when we talk about healthcare as another important social determinant, it's not just about like access of what institutions are in your community. So it doesn't necessarily make the large difference of whether or not you actually have Alzheimer's disease research center assess like in your community physically, or a hospital in your community physically, or an assisted living facility in your community physically, but how can you get into the door or access those services of those places outside of just their physical location? Do you have insurance or the financial means to access those services that are available, or are there other barriers that might make a difference? What are the hours? Are they available when you're available and when your relative is available? Are they on the bus line if you don't have ready transportation, or if your relative, you have a way to get your relative there, but maybe there's a conflict with your schedule, and having access to public transportation for that, could make a large difference. So these are all access concerns outside of just, does a person have insurance, or are they financially able to cover the cost of the services available for various healthcare services that can make a difference in care. And then, of course, there's a quality issue, which can vary based upon some of the national standards for quality and safety that are, in place, that has to do with the way that organizations are regulated, and can make a difference about like how those regulations might vary from institution to institution. And there's also a quality issue that is more one of perception, meaning how are the services delivered and how is quality perceived by the individuals that are accessing those services, that make them either more or less inclined to want to engage with particular institutions based upon how they're treated, or what the perceived benefit is of the services and how they are delivered. All of these things can make a difference ultimately, and not just the health outcomes of the person that is affected with a dementia related diagnosis, but certainly the family care partners that are supporting these individuals and helping them to navigate the healthcare system. And so when we think about culturally responsive care delivery, what we're talking about is, how do you give thought and intention to addressing all of these concerns in care delivery and then program development from the very beginning? How are we accessing the individuals that we're hoping to meet their needs, to make sure that our services and programs are inclusive for everybody, so that everybody that is within our community, and particularly the most vulnerable individuals within our community, can really access the services that we would like to provide. And so, to that end, much of the work that I directly have been engaged in, while I certainly have been a large part of and have deep interest in service delivery for the state, and more broadly, the nation, in helping to ensure that older adults, regardless of the particular diagnoses or residence location, are able to successfully age in place in their communities for as long as possible and as independently as possible, with the supports that they need in managing the chronic conditions that they have. Dementia care is a large part of that. And I've been particularly interested in how dementia care has been managed among Black older adults and their families. And part of that has to do with this idea that this particular population has experienced a significant number of disparities when it comes to these social determinants that you see here, whether it's having, more challenges with the economic stability, varying levels of education, and particularly this healthcare access and quality concerns. And so within the Black care partner population, some of the challenges that we've seen are noted here. And so there certainly are high levels of cardiometabolic health conditions. And so we see high incidence of hypertension and other cardiovascular health conditions, high incidence of obesity, which we also see, of course, in the Latino and many of the Native American, particularly Pacific Islander communities. And also high rates of diabetes. And again, also noted as high within the Latino and Native American populations, particularly again in the Pacific Islander communities. And so these conditions, of course, increase the risk for cognitive decline and future dementia-related diagnoses within these populations of caregivers, as well as increase other health risks, the risk for um, uh, death, and premature death. And it can make it more difficult for these caregivers to continue to provide care in the community. It can decrease their capacity to do so. We also see high levels of high intensity caregiving amongst these groups. So we're seeing large hours dedicated towards caregiving, 30 plus hours a week often, and providing high levels of care. And so when we're talking about activities of daily living, they're assisting with most of these. And so these are activities, of course, like being able to help with transfers and eating and getting individuals dressed, as well as instrumental activities of daily living, which are those other tasks that are necessary for independent living, like helping to get people to their appointments and helping to keep the house clean and getting meals on the table and making sure folks are fed and that their medications are ordered and taken, and managing the finances that come up in the household. And all of these things, of course, are laborious and also can be quite stressful because many of these individuals are also not spouses. And so there isn't the same sort of obligation, if you will, um, to to take care of these sorts of tasks. So, like, when you are married or in a partnered sort of relationship, and you have a spouse that develops dementia, many of these sorts of responsibilities may have been taken on by one person or the other, but there's sort of a, if you will, unwritten agreement about taking on these tasks as needed that doesn't necessarily transfer in the same way when it's a non-spouse that is the care partner. And you see these non-spousal relationships more frequently within minority populations and certainly within Black populations where you're more likely to see that the primary caregiver is a daughter or a son, that they're grandchildren or a nibling, a niece or nephew, or a chosen family, so the family that individuals have created for themselves that are a part of their community. They're people that have been with them for long periods of time that may not be blood, but treat them as, or maybe sometimes better than blood. And so these individuals cause some unique challenges in that when it comes to like these same high intensity caregiving needs, they don't necessarily receive the same sorts of support. These individuals are often younger. And so that means that they frequently are still in the workforce. And so the caregiving responsibilities can pull individuals out of the workforce or delay them from being able to be fully employed because of these responsibilities. We know that sometimes these individuals get selected due to maybe a bit more economic instability on their end. And so this adds like, another layer of that in some instances. And then as mentioned, the from some of our focus group meetings and other contacts with these caregivers, it just generally can feel different to have these sorts of obligations for care support when it is not a spouse or a partner. And that's not to say that there are not spousal or individuals that are living together as spouses that are caregivers, because that certainly is the case as well. And so some of the barriers that we see for these caregivers that have been noted most recently in some of the focus groups that we had with caregivers were things like having unexpected financial challenges. Even in instances where the care recipient had enough income to be able to support their own care needs, and they were even in one instance, the care partner, who in this instance was a niece, described that her uncle had, was well able to care for his own needs and paid for a facility stay. He was in another state. And so for her, it was still financially expensive because she still had to bear the cost of traveling back and forth across state lines to go to manage his care, to also help to coordinate his expenses, to get an attorney involved to help to manage his accounts locally. And Even though he had enough financial means to cover his own needs, it wasn't covering the financial costs that she had to bear as his primary caregiver. And so she had a deep relationship with him, and she did not describe the care that she was given as burdensome, but nevertheless, when she talked about all of the things that she had to adjust in order to meet his needs in the way that, she could feel good about, it was still very challenging, for her. And this was reiterated by many caregivers has talked about these various financial challenges that they experience in caregiving that, we don't always give voice to, and there's not always a way to address them. There's also often unrealistic family expectations. Particularly, one of the things that I often see with families, or when we talk about family caregivers or family care partners, is there's this sort of notion that is unpaid. And often see that there's a little uncomfortable shifting sometimes when we talk about whether or not there's pay engaged with these family caregiving responsibilities. And part of that is because sometimes within families, there are some payment arrangements that are made to help support some of the costs that are associated with providing care. And so, but the reality is that even when families are chipping in to help to cover some of the costs, the expectations that they have still may not be realistic, because you can't necessarily just pay away all of the rest of the family's responsibility in supporting, the individual who is also their relative too. And so sometimes this can lead to feelings of resentment. The individuals may not feel as though they can get the breaks that they need in providing support. And in instances where they're, whether or not there's any pay available, there still are other costs that can be incurred in a sense of wanting to get more support than often is what is made available. And certainly there are instances in which there are or is good family engagement, and families are working together as a team to adequately share responsibilities. There's often one family member that is taking the majority of the load in managing the care needs, and often another family member that has, again, unrealistic expectations around what that care should look like and how those decisions should be made. And so it overall can put a stress on the family. There's also emotional self-management as the individuals, the care partners have to adjust to these changing roles of what their loved one, like what their relationship looked like prior to the changes in their cognition, and coming to accept that, how that has changed and will continue to change as the disease continues to progress, as well as maybe some changes that they have to adjust to about what their expectations were for the period of life that they're in right now. I also think about a spousal caregiver from our study who spoke about having this expectation about traveling and wanting to really enjoy her retirement. to then find out that, like, her husband had developed, dementia and needed a significant amount of care, and not wanting to be tied down in that, particular role, because that's not how she had planned for her retirement to be. And so while she, was still doing her best to live out her dreams of being able to travel and trying to put into place the things that were necessary to see that he had adequate care needs met, it still, was taking a toll on her, of just that change in expectation of what you wanted in your relationship, and to see that that is no longer going to be the case. There's also neuropsychiatric behaviors that families have a difficult time dealing with, whether it's delusions, which is very common to be accused of stealing. And then that doesn't help with family dynamics when other relatives, particularly extended family, don't understand that this is a common symptom of cognitive decline. And then also accuse that same said family member of stealing or misappropriating funds, which can, be deeply distressing when you have dedicated so much time towards caring for someone. There often are reports of increased aggression, challenges with disinhibition. In most instances, it is more so about individuals saying things that come to mind that might be different from their typical personality. That the family is accustomed to. And then, of course, wandering is a concern that can be, stressful for families, that can make a difference. And then the other issue that has been raised by families are gaps in medical care and support. And so, whether it is not being engaged soon enough in the care process, so often family members come in the midst of a crisis. Nobody like gets to tell, like often is telling them early enough within the diagnosis about the diagnosis of mild cognitive impairment, or that the early signs of dementia, to make them aware that there's a change. They might start to notice something here or there, but by the time that they have to get involved, there's something, a crisis often has come up that has made them get involved, whether it is an issue with utility bills that might be getting missed, or some sort of financial issue that comes up, or a distressed call from another state because a relative isn't behaving in a way that is expected. And all of this can be, very challenging, and presents an opportunity for, I think, healthcare providers to think a bit more deeply about how to engage families. How can we encourage our patients that we're supporting that are have a dementia related diagnosis, of when to talk with them about engaging their families earlier to help to, make this support, to improve this support. So we say all of this to say that, all of this stuff is stressful, right? And when we talk about stress, we're talking about demands on the brain and or body. And when we deal with stress, we our bodies have to respond to stress in some way. Like, we have to change our behavior when we're dealing with stress in order to like adapt to the stress that we're experiencing. And our bodies will autonomously do some things to help to adjust to the stress that we might be experiencing on the physiological level. And so one approach to dealing with stress, or a stress and coping model or conceptual model that I often use in framing my own work, is what is referred to as the Roy adaptation model. And so when we talk about a conceptual model, it's just really a way of thinking about ideas and connecting them together. And so the Roy adaptation model is a way of thinking about stress and coping. And it suggests that when there's a stressor, or what in the model refers to as a stimuli, that it affects one of these four domains that's listed here: physical domain, interdependence, role function, and self-concept. So within the physical domain, of course, this is when stress has a direct effect upon the body. And so this is when we see like our cortisol levels change, when we see that fight or flight or freeze response that individuals experience, where we might see some of those cardiometabolic changes related to stress. The interdependence role has more about how we engage others for support. Like, how do we start pulling people in from our circle, from our community, to help us to support the stress that we might be experiencing. Self-concept has to do with our ideas about ourselves, our capacity, how we perceive problems. This is where spirituality would sit, that helps us to address stress. And then role function has to do with our role in society. So, are you a son or a daughter, a friend, a manager, a leader, etc.? And how does this perception about your role influence your capacity to deal with the stress that you may be experiencing? And then, of course, all of this is within a cultural context. And so, when we talk about more specifically these socio-cultural considerations, what we have to consider are questions like, what influences beliefs and decision making? So, as we think about the populations that we serve and who's in our community, you don't have to go and do like a whole presentation or information gathering about every single possible racial, ethnic group that lives in the community. Sure, it's good to be a part of the community and understand who the folks are that live there and what are the ideals and values that are important to them. But these are the sorts of questions we really should be asking everybody, because everybody has a cultural group that they belong to. And we would be remiss in thinking about this in a what do they need, right? So this is how we other individuals, instead of thinking about like these are ideals that are important to everyone. And so everybody has values and beliefs that influence our decision making. And so when we're doing our assessments within our organizations, and we're doing the work to support families, these are the sorts of questions we should be asking. It's like, what are the ways in which decision making is influenced? And so some of the questions you could ask are, when you have to make an important decision, who are the people that you usually engage when that takes place, or do you just kind of make it on your own? And sometimes people have to think about that, because immediately a lot of folks will say, well, I make my own choices, right? But when giving it some thought, often there is another relative or a friend or a group or people that folks kind of mull things over with before they make a final decision, that they like to get their feedback, about decision making. Are there other things that can make a difference? Like, for example, are there particular religious ideals or beliefs that can make a difference between like whether or not somebody might choose palliative care service like hospice? You know, what are one's beliefs about end of life care? Um, and who should be engaged and when that should be engaged. What resources are and supports are available from that individual in the community. And so, something like transportation, it may not be an issue for a person that is in a well-resourced community. So just because they don't have a car doesn't mean that they can't get to where they're needing to go if those available supports are a part of the community that they are engaged with. And sometimes individuals might need to talk with someone and ask these sorts of questions to help them to think about what resources are available in their own communities that maybe they haven't accessed or hadn't really thought about, because there's a lot going on. And so you might forget some of the resources that are available in your community for you. And then, of course, your environment plays a large role. How do the home, neighborhood, and community factors influence choices? So, like, what services are actually available in the home? Is the home, like, how many people live in the home? Is it an intergenerational home, or does only one person live there? Is the neighborhood a safe and walkable neighborhood? Does that allow for some activity and support? Are other services like home visits available? or because of the community, is it less likely that people are inclined to come to that particular neighborhood? Is it more difficult to get deliveries because of the zip code that the person lives in? Things that people sometimes take for granted, like being able to get a pizza delivered, when you don't feel like cooking, is a problem because there are some neighborhoods in which they will not deliver a pizza. And I don't think, sometimes that gets missed, that when because there's such a large divide between communities and where people live, and divides amongst socioeconomic status, where these sorts of challenges, I think, don't get recognized. So these are all factors that should be considered and thought about when we are trying to develop interventions that really reach broadly into the community and engage the community, and also thinking about what's already there. What are the services and supports that individuals are already using, and like what are the gaps? And so instead of sometimes developing and forming something new, how can we and add to what is already in place? And so, to that end, one of the projects that we have currently been developing is what we call the ACE project, which is Alzheimer's Companion Engagement Project, in which we mutually developed this with family caregivers the care partners of individuals with cognitive impairment, and specifically with Black care partners, to understand what their needs were, what the current gaps were, and some of the challenges that we sort of discussed earlier, and particularly thinking about having intergenerational support, having support services, and particularly support groups available outside of business hours, because people are often working and not able to attend support groups or educational events that are taking place in the middle of the day or in the mornings, having more events and support access in the evenings, making it accessible virtually, because it was challenging to try to find care for their loved ones, or to figure out how to make sure that their needs were still managed while also being able to support, the care partner to have a space. And then there were some specific education needs that weren't necessarily being addressed. Like, for example, we found that a significant number of care partners that are also over the age of 50 experience daily pain. And we've consistently found this, but and of course, when you're providing physical care assistance, so you have to physically lift and roll, and there's a lot of actual physical work that's engaged with caregiving at times, depending upon the level of where the person is within their particular dementia-related diagnosis, that this can actually present, some physical challenges, if you already are experiencing daily pain. And so it may be that maybe there's some pain or other health condition support that can be beneficial in managing their own health. So I say this all to say that with the support of our care partners, were able to develop a 6-week program that engages a virtual support group that is approximately about an hour long. There are groups of 4 to 5 individuals that work together over these 6 weeks to work through some educational content that covers the basics of dementia, goes over advanced directives, what they are, which advanced directives are most applicable, some information on pain management, behavior management, and some of the other key areas that caregivers have identified is important to them, particularly at the earlier stages of diagnosis. Um, and we're testing to see whether or not this makes a difference with and makes a difference in helping to either maintain or improve hypertension. And so we are monitoring blood pressure over the course of this study, and providing some wrist electronic blood pressure cuffs in order to do so, as well as asking some other demographic and health related information before and of course after these groups take place to see whether or not this particular type of support actually helps to improve caregiver health. So we are currently in the process of recruiting participants for this particular study. The QR code that is on the screen is the screening survey for individuals that may be here, or if you would like to share that with others. And here is my contact information. I know that there are often lots of questions, and so I tried to not talk the entire time so that we had some time for discussion here. So I appreciate you coming and look forward to the conversation.
And it looks like we have one comment so far. It says, Sharia, thank you for the wonderful presentation. When we talk about home care, an agency will not send their workers into a neighborhood within a certain time frame. This is an accurate representation of your pizza delivery analogy. There are bias on the part of social support workers who do not understand these communities' realities.
That's absolutely true. And it really, I mean, I wasn't being funny. Like literally, like I've been at houses where they will not deliver the pizza because of the zip code, you
Yeah.
know. And so like, and this it's shocking, and the fact that like, I'm glad that you brought that up. It's not just about pizza, it's about other basic services. Like what happens if you can't get home care? Or services that are meant to be ideal, like getting your prescriptions delivered, are problematic if, mail is delivered, or problematic in your particular area. You can't receive, the medications to help to manage symptoms in your care recipient. Like all of these are ways in which I think we can be more thoughtful about advocacy, and communities can be more thoughtful about what sorts of services can make a difference and extending support within, the communities that we want to reach out to, because that's something that like, some of our smaller organizations might be able to, assist with if there's a need that's has come up like that. And we got to look at the training, right? So how do we support clinicians that need to be in these areas so that they can be more comfortable about driving and being in areas that might have a higher level of crime, and understand what the risk is versus the actual risk versus the perceived risk, and how to make like good choices to be safe when you are in these communities that might be considered, riskier. But honestly, like, I don't know, I was a hospice nurse for many years and did home care for many years, and I don't think there's a neighborhood I haven't been in. And I will say there's a very different level of respect and support that comes with a healthcare provider being in a community that I don't think is really understood by organizations that choose to set these sorts of barriers around making sure that access happens.
All right. Can you put up the slide again with the QR code?
I sure will. Let me see here.
And how many folks are you currently enrolling into the ACE project?
This is a pilot study, and so the number of folks for this one is am I sharing? Uh-oh. One second. We're enrolling 36, and we have about 13 folks enrolled already. So it is starting to fill. So I would suggest that if people are interested, that they do that sooner rather than later. Here's that screen again, I think. Can you see? Is it yeah, okay. See, Hank?
All right. We'll go on to the next question. Oh, this is just a follow-up. Taxis or delivery services aren't available, and sometimes even EMS aren't. EMS is
It's
delayed in neighborhoods.
It is, and it's ridiculous. I mean, I was with a clinical group in the city who was having a cardiovascular event, and it took 20 minutes for the ambulance to arrive, you know, um at the site. And so like these are really valid concerns, but I think that these are opportunities to, I think, be more engaged in the communities to identify what these concerns are. And this is where we should be engaged in our legislators. Um, our city councils, our aldermen, all of these individuals, as well as holding some of these organizations accountable to let them know what's needed, in the community so that we can improve access to services so that we can work together to figure out how to address collectively some of these barriers. And the more we are actively engaged in the community, the more we can identify what these challenges are, right? So that we can hear about what the problems are that communities are facing.
All right, this one says, great presentation. Any insight into resources for language barrier, loved one reverting to first language, and memory care facilities in area not having folks that who speak that language, and family doesn't speak either.
Yeah. So I would say like the most immediate like for the family, I would say is the Google Translate app on your you can put it like on your phone. And it has a detection software because it engages AI that will pick up the language. And so that's like a first like immediate for family that could be helpful. But there are also through the agencies are all required to have language services available. Many of them use things like there used to be like an AT&T language line that they could subscribe to get providers or like translators in different languages. One of the challenges that I know this comes up is not just that individuals revert to their first language. Sometimes it's like a first dialect too, which adds another layer of difficulty because there might be variances in or more difficult to find somebody that can translate it exactly into that dialect, so it can make it even more challenging. I would suggest if there's a particular agency, then to reach out to the agency to find out what to let them know that this is an ongoing concern, to see what resources they have within that particular agency if you have like a home care service or somebody that's involved. But as I mentioned, if it's just like family, the Google Translate tool actually, like I said, works fairly good, and I think it's gotten considerably better over the years.
We had a couple questions about the printable flyer for this, as a lot of people don't use QR codes on their phone.
Sure.
Um,
Sure. We can send out the printable information as well. Stephanie has
yep.
the flyer and can send that out to the individuals who have registered. And then you can also email me and I can also send you the link and or send you the flyer.
And this one says, I'm sorry I might have missed this, but is there a specific area, city, state that this project is serving?
Nope, it's virtual. That's the beauty of it and we have had people participate in some of our other projects from all over. Many of our folks tend to come from the Midwest and northeastern states, but we do get people from all over that participate.
All right. Any other questions? Comment? Great presentation. All right, a couple more questions are coming in.
Okay.
Oh, this one's for me. I mentioned the April speaker series. Yeah, so the April speaker series, I can send out the flyer to that one. Um, right. In our follow-up email, so you can have the information for that. But it is an in-person event at the U of M Detroit Center, and we will have some research tables there, and we'll have three speakers from our center coming in to answer any questions you might have about dementia research and what goes on at the MIDRC. All right, thank you for your presentation. Thank you for your presentation.
So when I say care partner, Chuck, I'm talking about whoever not the person is that is providing support to the individual with dementia. So not necessarily both individuals. It's not like for dyads. It's whoever is providing care or the caregiver for this particular study. One of the things that we found in so much of the policy still refers to care partners as caregivers, but one of the challenges that we have around language is that when you're taking care of your husband or your wife or your grandmother, nobody necessarily thinks of themselves as like a caregiver, right? And so sometimes it's easy to get missed around the support services and things that are available. And I mean, to the same extent, I don't know that anybody necessarily thinks of themselves as a care partner, but when we've asked relatives, care partner seems to be the preferred term. All right, looks like there's no more questions.
Oh, great presentation, comments. Yep, I think we're coming to a close. So thank you very much for coming today. We'll give you your last 7 minutes back. Oh, it looks like we have another question coming in. Great presentation. Do you coordinate any care with physicians in the communities to determine the specific needs for the care partners? Also, do you do consultation services?
In answer to the latter, yes, I do consults all the time, I feel like. And in terms of working with physicians to determine care needs, I haven't been working directly with physicians to determine care needs. There is through the AAA, so the Area Agency on Aging, the state of Michigan has a referral program as well. So you can contact your local area agency on aging. You can call and they have referral programs where you can talk with them as well about like what sorts of care needs you have, and they can make referrals to services that are available based upon your county. That's why you want to call the area agency on aging based upon like where you actually live or where your loved one lives at, because the services will be based on like what they're eligible for, unless you also are over 50 and may need some services or may be eligible for services yourself. So, but of course, some of the challenges are that many of the services are income based, which presents a challenge for many folks.
Another thank you. This was excellent. All All right, if nothing else pops through in the next couple seconds, I will close things out for today.
And feel free
Maria,
to shoot me an email if you have other questions or things that come up. Usually there's lots of questions, so I said, let me make sure that there's some space.
yeah, yep. And I think everybody's gotten email reminders from me too. So if you have, if you didn't write something down, please feel free to respond to one of those emails. And yeah, I'm happy to follow up. Oh, follow-up question. Funding sources have changed greatly. Do you recommend any specific agencies that are more receptive to persons in need? I'll follow up an email with you.
Sure. So one organization I noticed in the Metro Detroit area is Universal Caregivers, that they do have some small grants available to support care needs, often like for respite and stuff like that. So that's another source other than the Area Agency on Aging. And then believe it or not, I think Easter Seals also may be able to help to provide additional information about local resources that are available, as well as funding to support basic needs. And that's one of the organizations that we were making referrals to, like during COVID, for like household stuff, like trying to identify like where to get groceries and transportation and things like that. So that's another place to look in. I think 211 is the information number for folks in the Detroit area for assistance.
Comment, a very far-reaching presentation and badly needed. Thank you.
Thank you.
It says the Alzheimer's Association offers respite scholarships as well.
Thank you for mentioning that. So there's a couple of places that have respite scholarships. So I do highly recommend between Universal Caregivers and the Alzheimer's Association reaching out directly if there are some financial needs.
All right. Well, thank you so much for coming out today. You have our contact information, and please reach out if you have any further questions. Thank you very much, and have a great afternoon.
All right. See you guys next time.